Certified by Dr. Pat. Leading innovation in fertility excellence.
Imagine for a second that you're sitting in a doctor's office. You're facing a surgery, and the surgeon sitting across from you is laying out the risks.
Right, the standard pre-op conversation.
Exactly. But they tell you that this specific procedure carries a notably high risk of permanently damaging one of your organs.
Wow. Okay.
Yeah. And on top of that, they say there's actually a very high likelihood that the problem they're operating on is just going to come right back anyway.
So it's not even a permanent fix.
Not at all. And to make matters worse, and this is the kicker, this surgery might actually severely harm your chances of starting a family in the future.
That is a brutal list of side effects.
Right. Now, hearing all of that, you would probably assume this surgery was an absolute, unavoidable life or death necessity.
Right.
Like you'd think there was simply no other choice.
Well, yeah, I mean, that is the only logical conclusion most of us would draw. We're totally conditioned to accept severe surgical risks only when the alternative is some catastrophic health outcome.
But what if I told you that this exact surgical profile describes one of the most frequently performed procedures in women's health today?
It's honestly staggering when you frame it like that.
It really is.
Yeah.
Today's deep dive is all about the medical management of endometriomas, which these are ovarian cysts caused by endometriosis. Sometimes they're colloquially called chocolate cysts.
Yeah, that's a very common term for them.
And we are basing our entire exploration today on a massive, highly provocative 2025 review. This was published in Reproductive Biomedicine Online, authored by Dr. Bülent Erman and his colleagues.
And I have to say, it is a truly critical piece of literature because it effectively forces the medical community to look in the mirror.
Yeah.
The mission of this review, and our mission in discussing it today, is to unpack a massive shift in medical thinking. We are basically revisiting a very common standard of care surgical procedure through the lens of the absolute oldest, most fundamental rule in medicine, which is first, do no harm.
First, do no harm. And why should you, the listener, care about this? Well, even if you don't have endometriosis or, even if you don't have ovaries, this is a brilliant masterclass in how medical consensus evolves.
Absolutely. It's a real-time look at how doctors and researchers weigh the true risks and benefits of literally any medical intervention you or a loved one might ever face.
It teaches us how to evaluate the treatments we're offered. Okay, let's unpack this. Where do we even begin when evaluating if a surgery is truly necessary in the first place?
Well, we have to begin with the foundation of surgical philosophy. In the medical field, there are three fundamental principles of surgery that have pretty much stood the test of time.
Okay, what are they?
A surgical intervention generally needs to accomplish at least one of these three things. Number one, preserving life. Number two, alleviating suffering. Or number three, correcting a dysfunction or a deformity.
Life, suffering, dysfunction. Got it.
Right. And if a procedure fails to meet those benchmarks, its necessity instantly becomes a matter of intense debate.
So let's apply that framework directly to endometriomas, starting with the most extreme scenario, preserving life. Because when someone hears they have a growing mass on their ovary, the immediate terrifying thought that jumps into their minds is cancer.
Of course. That's human nature.
Right. Does cutting these cysts out save lives by preventing or catching ovarian cancer early?
That is the exact fear that has driven a massive amount of these surgeries over the decades. And to be fair to the historical approach, the data does show a connection.
Okay, so there is a link.
There is. According to the research in the 2025 review, women with endometriosis do have a 93% increased likelihood of being diagnosed with any form of ovarian cancer.
93%. Wow.
Yeah. And when we look at specific types, there's a 3.4-fold increased risk of clear cell cancer and a 2.3-fold increased risk of endometrioid cancer compared to individuals without the disease.
I have to admit, if a doctor tells me I have a 93% increased likelihood of cancer or, a 3.4-fold increase in a specific type, my immediate reaction is get this thing out of you right now, like yesterday.
Totally understandable.
Those relative numbers are terrifying.
They are. But if we connect this to the bigger picture, we have to carefully distinguish between relative risk and absolute risk.
Right, the statistics trick.
Exactly. A 3.4-fold increase is a relative risk. It sounds enormous. But because ovarian cancer is exceptionally rare in premenopausal women to begin with, the absolute risk, the actual statistical percentage chance of a woman developing this cancer in her lifetime, it remains incredibly low.
So it's essentially multiplying a fraction of a percent. Like if a risk goes from 0.1% to 0.3%, you've tripled your risk. but you still have a 99.7% chance of being perfectly fine.
That is the exact mathematical reality. The baseline risk is microscopic.
Okay, that changes things.
It does. And furthermore, our ability to differentiate a benign cyst from a malignant tumor has evolved dramatically.
How so?
Well, historically, doctors might have relied heavily on MRI for a high-resolution image, or they just felt compelled to operate and biopsy the tissue to see what was going on. But today, transvaginal ultrasound has actually surpassed MRI as the preferred imaging tool for endometriosis.
Wait, I really want to push back on that.
Sure.
How is a standard ultrasound outperforming a multi-million-dollar magnetic resonance imaging machine? I mean, MRIs are famous for their soft tissue resolution.
It's a great question. MRI gives a beautiful, highly detailed static picture, but an ultrasound is dynamic.
Dynamic meaning moving.
Exactly. When a skilled diagnostician performs a transvaginal ultrasound, they're physically interacting with the patient's pelvic organs in real time. They utilize something called the sliding sign.
The sliding side, what is that?
Basically, they apply gentle pressure with the ultrasound probe to see how the uterus, the ovaries, and the bowel slide against each other. If they're adhered together by scar tissue, they won't slide normally.
Oh, that makes so much sense.
Right. Furthermore, the doctor can incorporate the patient's actual pain perception into the examination. If they press a specific spot and the patient experiences their typical agonizing pain, the doctor can map the exact location of the disease far better than a static image ever could.
I see. So it's the difference between looking at a high-res photograph of a locked door versus actually jiggling the handle to see where it's stuck.
Precisely. That's a great analogy. And because this dynamic ultrasound technique has become so advanced, we can categorize these cysts with incredible accuracy now.
So you don't have to guess if it's cancer.
Mostly, no. For instance, even if an endometrioma is quite large, say over 10 centimeters, which historically was an automatic red flag for malignancy, if it has the typical ultrasound features of a standard endometrioma without any other high-risk vascular findings, it's classified as ORAD-S3.
ORAD is 3. And what does that mean for the patient in practical terms?
It means the risk of malignancy is estimated to be only between 1% and 10%, and honestly, it almost always falls in the very low end of that spectrum.
But, I mean, I still struggle to see how leaving a 10-centimeter mass inside a patient is the safer option, though. Even if the absolute risk is 1%, why not just take it out?
You'd think so, right?
Yeah. Why leave a known growing mass inside a patient when you could just remove it and drop that risk to absolute zero?
Yeah.
It's like tearing down an entire house because you saw a single termite on the porch.
Exactly.
Sometimes the preemptive destruction is worse than the highly unlikely worst-case scenario.
That termite analogy is spot on, because removing it is not a zero-cost action. Remember the severe surgical risks we mentioned at the very beginning of our discussion?
The organ damage.
Yes. For premenopausal patients, the review concludes that undergoing this heavily invasive surgery solely to uncover a statistically highly improbable early malignancy, it simply doesn't justify the permanent collateral damage to the reproductive organs.
So it completely fails the first pillar.
It fundamentally fails that first pillar of preserving life.
Okay, so if the cancer risk doesn't justify the scalpel, we have to talk about the sheer agony of endometriosis. That brings us to the second pillar, alleviating suffering.
Which is a huge factor for these patients.
It's notoriously painful. Patients describe it as debilitating. So if the cyst isn't killing them, isn't the surgery justified just to give them their life back from the chronic pelvic pain?
Well, what's fascinating here is the massive paradox in how we understand pelvic pain. The great twist in the medical understanding of endometriosis is that the severe pain women experience is rarely caused by the endometrioma itself.
But how is that possible? You have a cyst the size of a grapefruit sitting on an ovary, taking up physical space in the pelvis, and you're saying that's not what is causing the pain.
In the vast majority of cases, no.
That is wild.
You're right. Endometriomas are rarely isolated biological events. The review notes that in about 70% of cases, these cysts are associated with what we call deep endometriotic lesions.
What exactly is a deep lesion, structurally speaking? Like, what does it look like?
These are dense, fibrous growths of endometrial-like tissue that extend deep beneath the peritoneum.
Which is the lining of the abdomen, right?
Correct. The lining of the abdominal cavity. They don't just sit on the surface. They actively invade. They attach to the bowel, the bladder, the pelvic ligaments, and most importantly, they infiltrate the sensory nerve fibers in the pelvis.
Oh, they get into the nerves.
Yes. When they invade these nerves, they trigger an intense, localized inflammatory response and cause dense fibrosis, which is a hardening and scarring of the tissue.
Ouch.
Yeah. That deep nerve-invading inflammation is the primary generator of the severe chronic pain, not the static, fluid-filled cyst sitting up on the ovary.
Make it make sense. So if a surgeon goes in, sees the big obvious cyst on the ovary, painstakingly removes it, but leaves those deep nerve-invading lesions behind. The patient goes through the trauma of surgery, wakes up, and the pain is still completely there.
And historically, that happens all too often. Removing the cyst without addressing the deep lesions simply will not cure the pain.
Well, the natural follow-up question is, if the surgeon is already in the pelvis with a laparoscope, why not just remove the cyst, A&D, spend the time meticulously excising all those deep lesions? Just clean the whole area out while you're in there.
Because completely excising the cyst comes at a massive, often permanent cost to the patient's future biological health.
This is the organ damage we talked about.
Exactly. To truly remove an endometrioma and prevent it from just refilling with fluid a few months later, surgeons have to perform a technique called stripping. They have to physically peel the capsule of the cyst away from the healthy ovarian cortex.
And I imagine that capsule isn't just loosely sitting there waiting to be peeled off.
Far from it. The capsule of an endometrioma doesn't have a clean, fibrous border separating it from the rest of the ovary. It's heavily integrated into the tissue.
You're essentially fused together.
Yeah, they share a delicate microvascular network. So when a surgeon physically peels that capsule away, they are invariably ripping away healthy primordial follicles.
Which are the eggs.
Right, the microscopic precursors to human eggs. And more importantly, they are severing the blood vessels that keep the rest of the ovary alive. This universally decreases the patient's ovarian reserve.
I know patients track their ovarian reserve through AMH, or anti-Mullerian hormone levels. Are you saying the mechanical act of stripping the cyst permanently tanks their AMH?
Yes. Stripping the cyst capsule reliably and precipitously drops a woman's AMH levels because you are permanently damaging the blood supply to the ovarian cortex.
So you're basically starving the healthy ovary of blood.
Exactly. You are essentially inducing premature aging in that ovary.
That is a brutal trade-off. You trade your ovarian reserve for pain relief that might not even work if they miss the deep nerve lesions.
It's a terrible position for a patient to be in.
What about just draining it? Like, instead of ripping the capsule out and ruining the blood supply, can't they just put a needle in, suck the fluid out, and leave the capsule alone?
Well, there are alternative interventions gaining traction precisely to avoid this damage. One is called sclerotherapy.
Sclerotherapy.
This involves using an ultrasound to guide a needle into the cyst, draining the fluid, and then injecting a sclerosing agent, usually high-concentration ethanol, into the empty cavity.
They inject alcohol into the cyst.
Yes. The alcohol essentially triggers cell death in the cyst wall from the inside out, causing it to collapse and scar shut without needing to physically rip it away from the ovary.
That sounds incredibly efficient.
It is, and the data clearly shows it preserves AMH far better than surgical stripping. But we must be clear, it's not risk-free.
What are the risks?
Injecting ethanol into the pelvic cavity carries a risk of chemical leakage, and there's a notable risk of severe pelvic infection or abscess formation. It's a valuable tool, but it requires highly specialized expertise.
Which perfectly sets up the third and final justification for surgery correcting dysfunction.
Right, the third pillar.
And in this context, the dysfunction is infertility. Because for decades, the conventional wisdom fed to patients was that if you have endometriosis and you can't get pregnant, you need a surgeon to go in and basically clean up the pelvis to make it hospitable for a baby.
That was the standard narrative, absolutely.
Does the surgery actually help women conceive naturally?
This raises an important question about how we interpret medical data, and it's where the gynecological community is having a real reckoning.
Oh.
Older studies from years past claimed that about 50 to 54% of women achieved a natural pregnancy post-surgery. And for a long time, that was the unquestioned gold standard statistic used to justify putting patients under the knife.
I mean, over 50% sounds like a fantastic success rate.
Yeah.
Why is the 2025 review questioning that?
Because those older studies were uncontrolled.
Uncontrolled?
Yeah, they had no control group of women who didn't get the surgery to compare against. The researchers were simply observing pregnancies after surgery and assuming the surgery was the catalyst.
Right. Correlation, not causation.
Exactly. But a much newer, rigorously controlled study looked at 244 patients with unilateral endometriomas, meaning a cyst on only one ovary that were over 2 centimeters in size.
And what do they do to them?
They just monitored them, no surgery. And they found that 43% of these women conceived within 1 year without any surgical intervention whatsoever.
Wow. Here's where it gets really interesting. I was looking at the source material, and the authors included this amazing piece of visual evidence.
Oh, figure 1.
Yes, figure 1 in the review is an actual ultrasound image of a patient and shows a healthy, natural intrauterine pregnancy in a woman who had bilateral endometriomas. She had cysts on both ovaries, not just one, both.
It's a stunning image.
How is that even mechanically possible if these cysts are taking up so much space on the ovary? Doesn't the mass physically stop the egg from releasing?
That image is so powerful because it shatters the long-held misconception that the ovary is somehow biologically broken or paralyzed by the mere presence of the cyst.
So the ovary still works fine.
The physiology tells a different story. If we want to understand how this works, think of the ovary as a garden, and the endometrioma is a giant, heavy boulder sitting right in the middle of it.
Okay, I'm picturing it. Boulder in a garden.
You look at that boulder and assume it's ruining the soil, that nothing could possibly grow there. But if you look closely, the biological processes of the garden are still functioning. The flowers, which represent the developing eggs, are actually blooming right next to the boulder just fine.
The dirt is still fertile.
Precisely. The dirt is still fertile. The cyst is taking up physical space, yes, but it is not inherently toxic to the hormonal process of ovulation.
That is fascinating.
But if a surgeon decides to yank that boulder out by aggressively dragging a massive tractor through your flower bed, the mechanical trauma of the tractor is what actually crushes the flowers and ruins the garden's delicate ecosystem.
That is a phenomenal way to visualize it. The surgery is the tractor.
Exactly.
So the data is basically telling us that for natural conception, pulling the boulder out mechanically does more harm than just leaving it alone and letting the ovary do its job.
That's what the modern data overwhelmingly supports.
But what happens when natural conception isn't the path? Like, what about patients who need assisted reproductive technology like IVF?
That's a whole different landscape.
Because if you go through IVF, you have to pump the patient full of hormones to stimulate the ovaries. Doesn't estrogen act like pure fertilizer for endometriosis?
Logically, you would absolutely think so, since endometriosis is an estrogen-dependent disease. Doctors worried for years that IVF hormones would cause the cysts to explode in size.
Right. It seems inevitable.
However, the review synthesizes a mountain of data showing that the hormones used for ovarian stimulation during IVF do not worsen endometriosis-related pain, nor do they increase the long-term recurrence or progression of the disease.
Hold on, how does that make sense biologically? If estrogen feeds the disease, how does a massive dose of estrogen during IVF not make it exponentially worse?
It comes down to acute versus chronic exposure.
Oh, I see.
The estrogen spike during an IVF stimulation cycle is very brief, usually just 10 to 14 days of stimulation before the eggs are retrieved. It's a temporary, acute rise. It is not the chronic, relentless, year-after-year inflammatory exposure that actually drives the deep nerve lesions to grow and cause fibrosis.
That makes a lot of sense. And what if the IVF is successful? Does a pregnancy make the cysts worse?
Actually, it is quite the opposite.
Wait, really?
Yes, if the patient gets pregnant, the ensuing hormonal environment is highly beneficial. During pregnancy, the massive influx of progesterone forces the endometrial-like cells inside the cyst to undergo a profound structural change called decidualization.
Decidualization. What is actually happening to the cells during that process?
Well, under the dominance of progesterone, these cells basically stop dividing. Their cellular matrix changes, they shrink, and they essentially become biologically inactive.
They just shut down.
Yeah. The pregnancy hormones chemically neutralize the mass, often triggering a localized programmed cell death within the cyst wall. The cyst generally shrinks and remains completely dormant while the body focuses on the baby.
That is incredible. The body basically uses the pregnancy to put the disease in a biochemical chokehold.
That is a perfect way to put it.
So if the IVF process is safe and pregnancy actively suppresses the cysts, what does the data say about patients who insist on having the surgery before starting IVF just to have a clean slate?
The systematic reviews are glaringly clear on this point, and it is a sobering reality. Patients who undergo surgery to remove endometriomas before starting IVF end up with fewer retrieved oocytes.
Fewer eggs.
Their ovaries simply produce fewer eggs because of the surgical damage we discussed earlier. And in some of the most robust data sets, those patients actually have lower cumulative live birth rates compared to patients who just left the cysts alone and went straight to IVF.
Lower live birth rates. I mean, that is the ultimate, undeniable metric. You agree to an invasive surgery specifically because you think it will help you have a baby, and it mathematically, biologically reduces your chances of actually having a baby.
It's a profound realization for the reproductive field, which is why the shift toward avoiding surgery is gaining so much momentum right now.
But surely there must be some situations where a surgeon has to operate, right? We can't just ban this procedure entirely. When is the surgery actually medically indicated?
There are absolutely remnant indications for surgery, and they are quite specific.
Okay, lay them out for us.
First, acute emergencies. If a cyst physically ruptures and spills its contents into the pelvis, or if it becomes infected and forms an abscess, you must operate immediately.
Well, yeah, obviously.
Second, as we touched on earlier, if there is a highly suspect malignancy based on rigorous dynamic imaging and family history, you go in.
Right, if it's truly cancer.
Third, if there is a coexisting condition called a hydrosalpinx.
What is a hydrosalpinx?
It's when a fallopian tube becomes completely blocked and swollen with fluid. That fluid is often toxic to an embryo.
Oh, wow.
Yeah, so if you are doing IVF, that toxic fluid can physically wash back down into the uterus and create a highly hostile environment, preventing the embryo from implanting. So that damaged tube must be surgically removed or separated from the uterus.
Okay, rupture, cancer, toxic fluid in the tubes. Are there any other reasons?
The last major indication is purely mechanical. If a patient is undergoing IVF, the doctor has to pass a needle through the vaginal wall into the ovary to retrieve the eggs.
Right.
If an enormous endometrioma is physically blocking the only safe anatomical path for that needle, the surgeon may have to reduce or remove the cyst simply to grant physical access to the follicles. You cannot retrieve what you cannot reach.
That makes perfect sense. But let's say a listener is in one of those exact situations, like they have to have the surgery because the cyst is blocking the IVF needle, or maybe they have a ruptured cyst. What is the absolute crucial advice for them before they get wheeled into the operating room?
This is perhaps the most critical takeaway of the entire clinical review. If surgery absolutely must happen for any of those valid reasons, patients must be aggressively counseled on freezing their eggs or embryos before going under the knife.
Protect the garden before you allow the tractor to drive in.
Precisely. You must secure your reproductive potential while your AMH and your ovarian reserve are still at their baseline. Because once that surgical stripping happens, you cannot get those lost primordial follicles back.
It's gone for good.
The damage is permanent.
So what does this all mean? If we zoom all the way out and look at this 2025 review by Dr. Ehrman and his team, we are looking at a total paradigm shift in women's healthcare.
We really are.
The historical knee-jerk reaction in gynecology has always been, see an endometrioma, surgically remove the endometrioma. But when we hold that practice up to the rigorous light of modern data, it fails the three fundamental principles of surgery.
It completely fails them.
It rarely saves lives because the cancer risk is phenomenally low.
Yeah.
Because it doesn't address the deep nerve-invading lesions, it often fails to alleviate suffering and pain. And far from correcting dysfunction, it actively damages a patient's fertility.
Exactly. For the vast majority of patients, utilizing medical hormonal suppression to manage their pain, or bypassing the cysts entirely and going straight to assisted reproductive technology, is a demonstrably safer, far more effective route.
It represents a massive victory for evidence-based medicine. It shows a discipline finally prioritizing the long-term preservation of healthy, functional tissue over the short-term, visually satisfying removal of a benign cyst.
Visually satisfying for the surgeon's ego, maybe, but a long-term nightmare for the patient's biological clock.
Indeed.
And, it leaves us with a rather profound final thought to mull over. We have just spent this time completely dismantling a highly common, standard surgical procedure, proving through rigorous modern data that it often does far more harm than good.
Right.
It makes you wonder, what other routine medical procedures are we blindly accepting today as unquestionable standard practice that a rigorous review 5 years from now will tell us actually do more harm than good?
That is a chilling but absolutely necessary question for all of us to ask. Thank you so much for joining us on this deep dive. Whether you are navigating endometriosis, facing a different kind of surgery, or just love understanding the intricate mechanics of how our bodies work, remember this: you are your own best advocate. Never be afraid to ask your doctor why. Why this specific surgery? What is the exact mechanism? And what happens to my body if we just do nothing? Don't let anyone bring a tractor into your garden until you've checked the soil yourself. Until next time.
Leading innovation, fertility, excellence. Live by Dr. Pat. Leading innovation in fertility excellence.